Sara Bartel. Thanks, Coop, for hitting that recording for us. And ChangeLab Solutions, for those of you who don't know us, our mission is healthier communities for all through more equitable laws and policies. And we're a team of lawyers, policy analysts, public health experts, and community planners who work on upstream community health solutions in partnership with cross-sector collaborations that involve government at all levels, community-based organizations, and health, school, and other public sector partners. I want to provide a disclaimer that because we are lawyers, we just want to let you know we don't provide legal advice or enter into attorney-client relationships. This is just an informational webinar. I also want to give a shout out to our partners at CDC OSH who are funding this webinar today. And our last little disclaimer slide, I just want to let everybody know that we are talking about commercial tobacco today and not traditional or tribal uses of tobacco. With that, I will hand it off to Jessica to ground us in some definitions.
Thanks so much, Sara. So to get started, let's start with the grounding definition of health equity, just to make sure we're all on the same page. This one is from Dr. Paula Braverman, who's an expert on health equity and social justice. And she defines health equity as meaning everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences. And so an important part that this definition highlights is that working to promote health equity means working on the root causes that lead to those inequities in our communities in the first place. We've paired this definition with the common bicycle images from our Wood Johnson Foundation, which you guys may have seen a bunch of times, showing that there is a pretty big difference between equality, which would be something like everyone having the exact same bicycle, versus equity, where everyone has a bicycle that's tailored to their exact needs. So thinking through, if you have someone in a wheelchair, just giving them the standard bicycle isn't going to work for them. So in order to have equity versus equality, you need to think about or you need to have strategies that react to people's specific needs. And at ChangeLab, we've identified 5 fundamental drivers of health inequity that are created by and therefore can be changed by legal and policy interventions. And so the first of those 5 is structural discrimination, including structural racism, which operates through policies, cultural norms, and institutional practices. The second we identified is income inequality and poverty at both the community and the individual levels, which can obviously impact important stuff like access to healthcare or cessation services. And it also has an impact on generational poverty and equity, things like the wealth gap, where we're seeing generation after generation of these cycles of poverty. The third is disparities in opportunities, such as access to quality education, jobs, economic opportunities. The fourth is disparities in political power. So that would be disparities that make it difficult to make your needs and goals visible to the government and institutional decision makers. So who are local health departments working with? And we're going to talk more today about community engagement and how that can inform your messaging and inform the work that you do. And then the last driver is governance that limits meaningful participation, or governance that limits meaningful participation. So how are the power, the money, and other resources and opportunities being distributed, and are they being fairly distributed so that people have access to make their needs heard and to pursue policies that help address those needs? All of these drivers are discussed in more depth in our blueprint for change makers, which lays out more info about each of the drivers and our approach to policy interventions that improve health equity. Sara will highlight that a little bit more shortly, and with that, I will pass it back to her.
Thanks so much, Jessica. So let's talk about how equity and these fundamental drivers show up in our work in tobacco prevention and tobacco control. So of course, we're all well aware of the disparate health burdens of tobacco use among different demographic groups and regional areas and even neighborhoods. And we know that the systems and institutions in our communities shape lived experiences that contribute to tobacco uptake and use. and that focusing on structural level changes can promote equity and empowerment and lift up community voice and local control over industry presence. This includes how our communities enforce policies to ensure that they help and don't hurt those they're meant to protect. At ChangeLab, as Jessica prepped up, we've got two equity forward products, the Blueprint for Changemaker and our Equitable Enforcement Guide, in addition to our tobacco prevention and tobacco control resources. You can read all about that on the website. At this point, I want to just say thank you to all of you for coming. Thank you, Julie and Ashley, for leading this discussion, and welcome. Julie, with that, I will hand it over to you.
Great, thanks Sarah, and thanks Jessica. I am really delighted to have a chance to work through some of these ideas today about how evidence-based messaging can help the work of ensuring that our policies and programs and practices are eliminating tobacco-related health disparities, how evidence-based framing strategies and messaging can move that work forward. So today I am going to be the main speaker today, but I'm definitely representing the work of a big group. This project, the Tobacco Disparities Framing Project, has been going on since 2017 in partnership with ChangeLab Solutions. Here at Frameworks, an entire team of social science researchers worked on this, as well as communication strategists. We have been delighted to have the ongoing support and partnership and leadership from CDC's Office of Smoking and Health, and also delighted to have some additional funding and strategic insight from California Tobacco Control Program. This project, our long-term goal is to ensure that in every community, there are evidence-based approaches in practice that are eliminating tobacco-related health disparities and really driving health equity. In the short term, the way this project can move that forward is to equip folks like you, people in the tobacco prevention and control community, to use evidence-based framing in their outreach and messaging, in changing the conversation on what commercial tobacco is, how it's being used, deployed and targeted to communities, what are the effects of that, and what can we do to improve the situation. So today I will go through three main framing strategies, and then we'll have Ashley LeMaistre from Austin Public Health talk a little bit about what it's like to use these strategies. But I'm going to walk through the research goals, methods, and findings that we have just really briefly, dig in, spend most of our time today offering evidence examples of what those messages look like in practice, and then we'll finish up with some reflections on what it takes to put this work into practice. We'll stop at a few different points to pause and take questions and comments and insight. So I want to encourage you all to put things in the chat as we go through. Sarah's gonna respond to things quickly if she can, but we'll pause at intervals and make sure we're having a robust discussion, as well as some time at the end to talk to kind of speak back into the group. All right, so research goals, methods, and findings. I'm going to share just a bit of background about this project, although again, most of the time we'll spend on the good stuff, the frames that work. So I want to acknowledge first that this project had a very active advisory group that really represented the perspectives, needs, and concerns of the communities most affected by tobacco-related health disparities. So this group helped us sharpen research questions and our methodological design, rollout strategy, craft taking a higher level finding and really applying it to issues that are real live in communities right now. So just wanted to make sure that everyone there got some acknowledgement. And I see a few folks on the call today, so thanks for being here. And what is the project? What are our goals? Again, our goals are to make sure we've got the language that we need to build support for eliminating tobacco disparities and advancing health equity. And we decided with analysis to do that, we need to make the issue more salient. It needs to be on people's radar screens. It isn't probably a shock to us who do do this work all day, every day. But I'll show you some interviews where people are just really not thinking about this. It's not just enough to make people aware of an issue. If they're misunderstanding the issue, the awareness can actually backfire in some cases. So we wanted to, as we were building awareness, make sure we're also building understanding of the root causes and the bigger picture solutions for the harmful effect that commercial tobacco has. And we wanted to shift attitudes. Any of you who have been working in this space know it's a very individualized issue. Why are, those particular individuals who are using commercial tobacco making that choice? We wanted to shift attitudes away from individual responsibility toward collective responsibility, and shift attitudes away from fatalism towards collective efficacy, a sense that if we do something, it will make a difference. We wanted to accomplish all this critically because while reducing and avoiding further stigmatizing or blaming the communities that are most affected. We know once you start to cross, kind of any health topic with a community that's marginalized and oppressed in society, very toxic assumptions kind of come out of that cross. And so we wanted to make sure we were finding frames that attributed responsibility to root causes and structures and systems, and reduced stigma and blame on affected communities themselves. So that's a tall order. In order to pull that off, we've been, again, as working for about 5 years now on this. We began research in earnest in March 2018, and that lasted about a year and a half. We then have, for the last couple of years, been really pushing to make sure that we've got workshops, presentations, tools, resources. I think I did 43 talks on this during that time, which would not have been possible in the before times, was definitely possible in the Zoom era. And we are evaluating this work actively right now. So thanks for being here. The research base has two big parts to it. One is the descriptive research, which is how people were thinking before, right, any kind of framing hit them. And the second being reframing research, how to spark new thinking. How can we move people not from where they, not leaving them where they are, but pushing them more towards the scientific and evidence-based and equity-based perspective on these issues. So that research is just a high-level summary. Again, the descriptive research was essentially qualitative. So we did a series of interviews with experts in the field to really discern what were the key points that needed to be communicated to the public. We then went out and did interviews with ordinary folks across the nation. Our sampling strategy included folks both within and outside the sets of states that Truth Initiative has called Tobacco Nation. So we were purposeful about that. We also selected these locations in order to give us as much geographic and racial and ethnic diversity as we could pack into a relatively small qualitative sample. That helped us. We mapped across those interviews to see kind of, whether you're in Billings or Chicago or LA, and whether you're talking to a younger person and an older person, a smoker or not a smoker, people who use tobacco or not, whether or not, no matter what kind of conversation you were having, what were the assumptions that kept coming up again and again. And that gives us a high level kind of broad analysis that you can use in lots of communities to say, all right, no matter where we are, this is part of what we're up against in public thinking. With that diagnosis in hand, we can then really craft specific tools that get at those misperceptions or outdated understandings. So we create framing strategies that we believe can build understanding or nudge attitudes, those sorts of things. We tested those in rapid on the street interviews. A lot of that research was done in the before the pandemic. So these were on the street. We're doing these on the screen these days. And then we took the winning interviews or the winning ideas from that rapid qualitative testing into a series of 2 large-scale controlled experiments. One that test messages against each other. One of those experiments reflected the population of the United States. A second experiment was done in California only and represented the demographics of California at the time. Altogether, this project sampled more than 10,000 Americans in seeing kind of what frames can move folks, again, from where folks start to where we hope that we can get them. So overall, if I had to summarize all of that in just a few words, the major takeaway is that to move this issue, we recommend that the tobacco prevention and control movement as a whole move away from a traditional public health frame that simply emphasizes widespread health impacts and move towards a justice frame that emphasizes the principle of health equity, examines root causes, and advances solutions designed to eliminate disparities, not just create overall or average improvement. I could say all that by saying, we need to stop talking about it as just a health issue and start talking about this as an unjust health issue. That sometimes makes people say, yes, give me the thing that I can do to just switch people from one to that. So I've got here a picture of a switch on the screen, but it's not as easy as merely flipping a switch. It works a little bit more like this contraption here with these many different, I think technical term is doohickeys that you need to adjust and calibrate. This is a sextant, used for navigation, sailing navigation before the era of GPS, but it's got many small pieces that you need to really calibrate again and navigate your message toward the direction you want folks to go. So we'll walk through some of those. One thing that can help create that that sense of where you're going is this higher level kind of overall narrative. This narrative, we have found this structure of principle, process, problem, and then proposal helps people really wrap their mind around any social issue that folks aren't thinking about all day, every day as they go through their days. Most people are not thinking about most issues most of the time. This kind of narrative really can, again, invite people into the issues that we as advocates and public health experts have a much more fluency with. It starts with, again, a principle and aspiration that we want to or a value that we want to uphold as society. In this instance, the value or the principle that we found was the way advocates were talking about it, but also the way that resonated most broadly across Americans was to just say straight out, this is a matter of justice, that a just and fair society values every person and their health. And if we are really committed to justice for all, then that calls us to address the harmful role of commercial tobacco. So it can be used verbatim, just like that. It need not be used verbatim. This is a kind of an organizer, a set of themes to go through, but to start your communications with that. Then get into a process that's at play and a problem in that. As advocates, we often just say the problem and leave out these first two beats of the narrative, and that can tend to have that can lead to people wanting to avoid the issue rather than approach it. We want to pull people in to our issue. So giving folks a little bit of background and framing that in a way that lets them see what is unfolding, that can be very helpful. So here, the basic idea is that the process is that there are widespread protections or widening protections that we have put into place. And as a nation, we've steadily expanded tobacco protections over the decades. So there's less smoke in the air and fewer ads for deadly products on the air. And that has saved millions of lives. The problem is that those protections, which most Americans can take for granted, are less likely to cover the places where people of color, people who are LGBT+, people with lower incomes, people with behavioral health conditions. It's less likely to cover the places where those people live, work, learn, and play. And so then we need a proposal. If we just leave people with a problem, it won't just shock them into action. They won't just reason their way to what we should do. We need to give a clear sense. And again, the high level language that can cover lots of things is that to treat everyone fairly, we must extend tobacco protections to every community with no exceptions. So as I go through today, I'll start and go and show you a few more examples of this first beat in this narrative with the justice frame. I'm going to skip over to the solutions frame, the proposal, because it's really important to make sure you're always including that, and then show some tips and techniques for building in that explanation in the middle, the process, and the problem. So I'm just going to pause for a second and see if there's anything in the chat that needs request.
Thanks, Julie. Yeah, we don't have any questions. I just want to remind everybody we're not sharing slides, but we've got links to these materials. There are so many resources available that are pulling on that Julie is pulling on for the slides themselves. So the links are in the chat. If you need any extra support tackling through them, please keep those questions coming in.
Yep, for sure. Thanks, Sarah. All right, so that first beat in the narrative, we want to make this a story. The issue of tobacco-related health disparities, it needs to be much more than prevalence or higher rates of health problems in different communities. This needs to be a story about injustice and fairness. I'm going to show you a little short clip of videos from some of those on the streets interviews that shows how people are connecting the problem, like what are their associations with the problem.
And so would you say that the effects of smoking are different for some people or worse for some people than others?
Some people can smoke a bunch of tobacco and probably not ever get cancer in their life.
I know a lot of old farmers and ranchers that have smoked all their lives, and they seem to be, they live into their 90s.
One person can obviously smoke for 90 years and not have a problem, and the next person can die of a heart attack at 40.
Do you have a sense of why that happens?
No, I don't.
Okay.
Of course, yeah, everybody's system's different, right?
I think people are definitely genetically more prone to have the effects be worse.
I don't know. It's genetic or hereditary. I don't know.
Yeah, I mean, if you're sick, it's going to be worse for you.
It's really just adding another factor to the existing person that a condition or the existing conditions that a person would have.
I think that if you have like asthma or if you have like secondhand smoke and you're not used to it, I feel like that would be really bad for you more than other people.
So this video shows that people aren't just individualizing the cause of harm from commercial tobacco, the sense that, people choose to use that and therefore cause their problems, but they are individualizing the consequences. People's top of mind current understanding is that whether or not people are experiencing harm from commercial tobacco comes down to a personal health situation, whether that's the mythical genetic makeup that supposedly protects some people from any harm, even though they smoke till they're 80 or they're 90, whether it's a respiratory condition that could be exacerbated by smoking. People went again and again to personal circumstances. Public was not thinking about tobacco-related harms in systemic terms at all, much less as a justice issue. So it's clearly time to reframe, but how? So in experiments that I mentioned that sampled thousands of Americans nationwide, we found that many of the ways that public health advocates were framing the issue of tobacco-related disparities just weren't working. The most common way of talking about tobacco-related disease is to assert that it can be prevented, right? That to simply say it's the leading preventable cause of death and that sort of thing. When we tested this for its effects on people's attitudes and policy preferences, we found that this message had no measurable effect on the public. Statistically speaking, it was the same as saying nothing. Another strategy in use was to talk about the economic toll of tobacco in terms of lost productivity or avoidable healthcare costs. That might work to move a particular policymaker, but it definitely does not work with the overall public. In fact, we found that this argument reduced support for tobacco prevention and control, and it reinforced stigma with people saying smokers are harming the economy. Thirdly, finally, we saw that some advocates in the tobacco prevention and control movement were trying to elevate the equity dimension of the issue within the field by taking a, hey, we've come so far kind of approach. And that makes sense for engaging insiders without coming off as, judgy or blaming or that sort of thing. But it definitely did not work for the public. It led people to be skeptical that tobacco control did any good at all. And they blamed the affected groups for using commercial tobacco. So what did work? A simple, explicit appeal to the ideal of justice. That increase support for policies designed not just to create overall improvement, but to eliminate disparities in particular. Things like reinvesting tobacco tax revenue in Black and Brown communities. And unlike other ways of defining what was at stake, it did not spark or reinforce stigma or blaming of affected communities themselves. So let me give you just a couple, these are some of the ways that we can express this ideal of justice. Again, this is a theme that you can express in lots of ways, not a script. This is not 3 magic words that we expect everyone to say the exact same way every time, but a theme that you all can elaborate and express in different ways that resonate, that are apt to the communication and resonate in your community. So here's a couple of examples on the slide there, but I'll show you some from the field. So this is some of the recommended language here from the Wisconsin Department of Health. Currently, not everyone has a fair and just opportunity to be as healthy as possible. In addition to targeted marketing from the rural tobacco industry, obstacles like poverty and discrimination increase rates of retail tobacco use. This leads to poor health outcomes for those with fewer resources and less power in society. A second example from the Indiana Department of Health: everyone deserves a fair and just opportunity to be as healthy as possible, free from the harm commercial tobacco can cause. So this kind of framing helps us to advance an affirmative vision for health equity. It helps people to see what we can gain, not just what we're losing. It starts things off on a more positive note without hiding the problem or shying away from it, but saying, hey, we want to move towards something which is greater fairness and health. One more example of what this might look like. Here on the left, we have an example that is taken from existing groups, communications, and it just really points out the health toll, right, in this case on Indigenous people. Indigenous people compared to the general population have a higher risk of death and disease caused by using dangerous commercial products such as cigarettes, smokeless tobacco, and cigars. Cardiovascular disease is a leading cause of death among American Indians and Alaska Natives, and lung cancer is a leading cause of cancer deaths. So this defines the problem as the destructive health effects of tobacco in Indigenous communities. But as the research I just showed you, it just doesn't work. And here's our interpretation of why. It's not new news, for one thing. The tobacco prevention and control movement has been effective in getting across the idea that tobacco harms health. So by focusing only on the health impacts for only this community, the response we see in the public is kind of something like, well, didn't they get the memo? On the right, but we can make a different type of argument, zeroing in on the same disparities for the same kind of community, and show more about that. Instead of focusing only on unequal outcomes, making the story much more about prevalence or negative health impacts, instead making the story about justice and fairness. So a just society that's ensures that no person, regardless of race or ethnicity, is exposed again and again to things that we know are harmful, yet we tolerate continued exposure to secondhand smoke, which can increase the risk of lung cancer by 20 to 30%. More than 1 in 3 Indigenous people in the Midwest are exposed to secondhand smoke in their workplace, and state smoke-free laws don't automatically apply in tribal areas. So this is making more of an argument for health equity policies by appealing to this idea of social justice, by which I mean the notion that we as a society have a responsibility to ensure equal protection and remove unfair obstacles for all. It starts off by explaining what justice means in this context, and it shows where we as a society are failing in our responsibility to offer equal protection. Overall, this is shifting the frame from who is affected to who is responsible, from unequal outcomes to unfair practices. In that, once we start off with that claim, we want to also make sure that we're moving people to the kinds of solutions that would make sense to appeal to fulfill that obligation to justice. So we want to ensure that in every single communication, we are pointing out a solution, that we are showing how improved tobacco policy can unblock that path to justice. This is really important to show solutions because, and as I'm going to show you in these clips I just have, people have a very limited set of solutions that they can imagine.
Than other people.
What do you think needs to happen in the country to like reduce tobacco use?
That's a good question.
Oh, I don't know. I don't know about that one.
My first thought is education.
There's a lack of education.
I think that there should be more of an awareness of the long-term effects.
It seems to me like I see more and more young people using tobacco than I ever used to.
People who are addicted are going to keep buying them regardless.
So I don't really know if there will be a way to avoid it.
It's never going to go away until they're gone. Yeah, I don't think they ever reduce that.
All right, so you can see here that people have a few solutions in mind. One is there is no solution. I don't know that we can do anything about it. And then the second one is maybe is really around education, awareness, individual behavior change. Of course, we know that promoting cessation is important way of reaching folks who are currently harmed by commercial tobacco, but that's not the only thing we need to do. And then people move towards what they see as unrealistic solutions. So when they say, oh, nothing will happen unless we ban it, they're not deep into an analysis of how do we reach tobacco end game, right? They're saying that's unrealistic. There's really nothing we can do. So we want to encourage you all to always, again, make sure you're always pointing to a solution. We want to ward off fatalism by highlighting what we can do. I also want to encourage you to ensure that that solution spot can be filled with collective solutions. If we raise a big problem but don't mention the possibility of big solutions, we can spark or reinforce those fatalistic attitudes I just showed you. We know that many public health issues can't be solved without collective solutions, things that operate at the level of the community, state, et cetera, nation, yet people just don't know about them. So they think they land on awareness because they can't imagine, they just don't have the familiarity to understand, to name other solutions. And then also we have found time and again that when we emphasize collective solutions, that is part of destigmatizing the issue. It focuses people's attention on social and policy context, which counterbalances that tendency to blame individuals and affective communities. In general, I want to just say that effective solutions frames are collective. They're community level. They're things that are amenable to policy, which can be statutes and legislation, but also can just be any decision of an organized group to act or not to act. So that can be an institutional policy. They should be concrete, specific, descriptive, and possible to visualize and grasp. And they should be conceivable, feasible, and realistic within reach. In general, it's important that we ensure that we are pointing out using plain language to make the public health solutions really simple and easy to understand. So if you looked at some of these, I think this first one was comprehensive smoke-free policies paired with cessation access. But we could talk about that in simpler language by saying adopt and expand smoke-free home policies while increasing access to support to quit. Instead of overturning preemption, which let's do that, but plain language version of that is let local communities create stronger smoke-free air policies, and so on and so forth, using plain language to make these public health solutions clear and easy to grasp. Another example, these are from Nebraska and South Dakota. Instead of, often if you're in an agency, you can't advocate, right? But you can certainly educate. And so here are, instead of, let's do this, let's take these steps to decrease youth tobacco usage. Here we have this, these are simply ways to create, to decrease tobacco youth use. Nice and clear language there, plain text with images that illustrate. Again, same sort of things that I point out from this example to South Dakota. All right, questions and comments. I have seen the chat picking up, and looks like maybe I need to reframe my reframe a little bit. But Sarah, can you, I had one eye on it, but can't read it all specifically.
Thanks. Yeah, Julie, we've got a couple different comments. One is about big tobacco using health determinant language to keep or shield vapor products and menthol, giving local leadership talking points that's in this health determinants language. So just wanted to lift that up and see if you had any reflections on how the industry is using their own social justice frames, maybe.
Wait, can you, sorry, give me the heart of that question again?
Well, so it's sort of a comment, and I'm wondering if you have any reflections, or maybe we just let it lift it up and then move on. But it's someone who's commenting that big tobacco is using health determinants language to protect vapor products and menthol, and they're sending these talking points to local leaders.
No, I guess I was not aware of that, but I'm not surprised. I think that if they are, if tobacco industry is picking up on that, to me, that's further evidence that they think it can be effective. And the, folks on this call know way more about this than I do, but the way to debunk that sort of thing is to really call it out as a cynical distraction rather than genuine care. And to point out, respond with evidence that points that out, so that it's right that they're just hiding the ball there for sure.
Yeah, thanks, Julie. The other question that came in is about working in rural communities, and I'll let you know that I've highlighted everyone. There is a rural focus guide that's available on the webpage where all of these tools are listed, and you can scroll on down and click through to get to the guide that's specific to your issue area, and it includes one for rural health advocates. But the question here is that rural folks have talked about the way funding is allocated in states to rural areas in a way that's unequal and unjust, this commenter says. And so the term equity is actually disliked in rural areas. I wonder if you have any thoughts or can point us to anything in the guide that might be helpful when having those conversations.
Yeah, absolutely. So first of all, I should have included geographic disparities, right, as part of the groups that this research was designed to address the needs and concerns. So if I didn't say that at the top, that was an omission. And so absolutely, this research can and should be used to press for the kinds of policies, practices, programs that we need in rural areas. Second of all, there are a couple of points, places in the toolkit that would help to make the case for rural health in this topic. One is the talking points for rural health advocates, and the second is within the pointing out inequity, lots of data points that really show how that is quite unfair and that sort of thing. The equity around the word equity, I find tricky with the public. The number one connotation with it is that it has something to do financial, like equity in your house, equity in a business. That's what we hear kind of in our on the streets interviews. That's what people think it is. But if people know what it is, then, or think they know what it is, right, then they often hear it as a political term, and that can close some doors. So justice and fairness are, as long as you're describing what you mean by that and explaining that in a way that gets at the idea of equity, I think that can be one way to ensure we're moving this forward across states with big rural populations or large rural areas. And also, I mean, I think that really the part of the strategy that advocates really guided us, encouraged us, was to make this not a zero sum, us versus them, this group versus that group, having this sort of problem that it's really, we need to show the process is affecting lots and lots of communities and not allow big tobacco or anyone else to pit one community against the other, right? So I think it's we want to shine a light on the specific ways that this is harming communities, but also show the process that's affecting lots of folks. And then I'll just speak directly to I did read the comment now about I'll take this last part of sentence off. Part of this is an artifact of kind of how much space I had. This was, folks that were working specifically on the issue of smoke-free casinos, and wanted to ensure that you're really pointing out the secondhand smoke issues in workplaces, not just casinos, lots of workplaces that where Indigenous people may be employed. So I will give that another pass. And thank you for bringing that attention.
Yeah, and thanks also for raising up the importance of thinking about, tribal partners are really crucial to this work, but they are sovereign nations. And so it is a different type of partnership, but a very important one. So we really appreciate lifting that up. Julie, are there links to the video clips that you're showing in the research materials? Is it possible for those to be shared afterward, maybe if they're not in the tools?
They are human subjects video, so we are not at liberty to share them out of context. There we go. Okay. But you can share this webinar with
yes.
friends. Yep, great.
Okay.
All right. Final point before we get into hearing from Ashley and getting into more questions, which is to, if we're going to lead with justice, and we're going to ensure that we're leading toward a clear collective solution that folks can take. The connective tissue there, and perhaps the one framing superpower I like to give everyone, is to center explanation. So I love this quote that's coming up on, 50 years old now. Geez, that means I'm coming up on 50 years old now. Which is to, for social change to occur, the social arrangements that are ordinarily perceived as just and immutable must come to be seen as unjust and mutable. And I'll speak for myself as an advocate. I'm usually pretty good at talking about the unjust part, and less skilled sometimes at talking about helping people understand the mutable, that these things can be changed, right? There's space for intervention. And explanation is the place where we can make that space for people to be able to visualize where we could do something that would address the injustice. So instead of missing or misplacing responsibility by saying things like, it just is, this problem's just disparities exist among populations, which is a sentence I have seen innumerable times throughout the course of this project, that's just leaving way too much room for people to fill in why those disparities exist. And we know that they'll fill in, likely to fill in with negative stereotypes about affected groups. If we have a missing actor or a passive voice, youth are highly exposed to tobacco ads. So that's like mistakes were made. Who did it? Who's exposing them? And so that again leaves too much to the public imagination. And then we are still seeing language that is really blaming smokers. Such as, this is from a state tobacco website, every year thousands of non-smokers die from exposure to someone else's tobacco smoke. I've seen another one that if pregnant women would just quit smoking, we would save X number of infants' lives each year. So that really, not just inadvertently, right, leaving out language that leads people to think about individual responsibility, but there really are still lots of communications out there that are directly blaming smokers. So instead of doing those, and sorry, I know smokers is not the person first language, and so I apologize for that, but it really, this is meant to reflect public language in this particular instance. So instead of leaving that out, we want to take people down one of these causal pathways. The first being that tobacco industry saturates some communities with targeted and tailored marketing, and that some Americans are protected from secondhand smoke and others aren't. Those two, the field is pretty good at talking about those. Those are in wide use already. These second three are emerging, right? And I think need this third one is getting a lot of attention right now about tobacco companies pushing flavored products to entice certain social groups with the current commentary period on the proposed FDA rulemaking against menthol as a characterizing flavor. This is getting a lot of attention right now, but really ensuring that people understand why, right? Why and how that makes a difference. Pointing out, not just saying some people aren't doing cessation at the, some groups aren't engaging in cessation efforts, what they, to the extent they should, but flipping the responsibility there and pointing out that we are putting up barriers to treatments for nicotine dependence for some groups. And then this last one, this was, I think, an innovation of this project to really pull together the experts and advocates that wanted to connect commercial tobacco use and related health problems to root causes like the experience of systemic and pervasive discrimination, whether that's because of your gender identity or sexual orientation, whether that's because of your race or ethnicity, whether that's because of your perceived of your education level and therefore your perceived kind of social status. But that kind of stress of poverty and discrimination can push people towards commercial tobacco use and can compound the health problems. Putting in that stress connection is a place where we want to encourage the field to go. So when we put in one of these explanations, it really can, again, start to shift the uptake or the picture of what's happening. So instead of just listing the subpopulations that are affected, as you see here on the left, this is pretty typical, has been pretty typical messaging on this up to date. Instead of just saying, here are the groups, right, that are affected, instead, why, right? It's less protection and it helps to explain why that's happening. I want to give this example, which I think gets to a really great expression, again, of a theme. If the theme is that tobacco industry is pushing flavors to some communities, this is a message in that frame that comes from the campaign We Are Not Profit out of California, sponsored by the California Tobacco Control Program. So let's see if I can get this to play.
But big tobacco thinks every black face is a place to make a quick buck. Give to our communities to gain trust, but still filling us with poisons and calling it culture. Pick bills off our bones like vultures. I'm not a prophet, but I can see menthol sell cheaper in black hoods. Like vultures target dying things. I'm used to seeing our community being targeted by people looking for money. When I heard that big tobacco was targeting black people, I wasn't surprised at all. Unfortunately, we are seen as easy targets. Big tobacco has targeted our community specifically. You gotta learn first, and then you can do something about it. Fight back at wearenotprofit.org.
And this campaign launched, I would say, about a year ago at this point. It was, I believe, after the restriction on the sale of menthol passed in tobacco, and then kind of got unpassed for a minute, and in order to move and build community understanding and support in the lead up to a vote on the issue, this was the kind of campaign that was put out, and I think it's been getting a lot of good reception as far as the evidence that I've seen goes. But all this is to the point that this idea of expressing that causal pathway does not have to be wonky wonk wonk, nor should it be. It's really explaining, and it's explaining it again in lots of different ways through lots of different messengers, styles. So if that makes sense, you are now ready for your pop quiz. If you want, you can just participate in your mind, but if you'd like, you could also find your reactions emojis at the bottom of your screen. Which one of these is really explaining? Which one is showing what affects what? Why is it happening? Give you a moment to read those two and indicate your answer. All right, if you picked, put up your heart instead of the ta-da. Yes, great. See lots of great answers there. This again, it does not simply say what's the prevalence, right? What's the statistic we're seeing, but why is that happening? And again, it can shine. That why is not falling from the sky. It's pointing directly at the kind of disparity we wanted to point out using the statistic, but making sure that there's not room for people to fill in a story that the problem is with that group, with those people, that sort of thing. All right, and then the which explanation. The explanations that you offer are going to vary according to what's the proposal that you put in. So if you were trying to move towards a sense of we need, less state level preemption of local smoke-free policies or local tobacco restrictions. So if that's what you were trying to move folks toward, you'd want to give people the background that they need to understand that and introduce the problem in such a way that this proposal is like, of course, that's what we should do. So here I would start with, the fact that if we're trying to get to smoke-free air policies, with the background information that because there's no safe level of exposure to secondhand smoke, many communities have adopted smoke-free policies to protect residents. So that's framed in a way that is, again, clear, but pointing responsibility and showing that there's policy level solutions that we can put into play. And then what's the problem? Well, 8 of the 10 states with the highest proportion of Black residents have state laws that prevent local communities from setting up those stronger local tobacco control rules. I believe that there was a very similar number for folks with the states with the highest rural populations, might have been 7 out of the 10 states. And you can find that in pointing out injustice source in the toolkit. So really crafting that in a way that points to the bigger context and how our current protections are uneven, unfair, unjust. But if I was going to go to a different solution, which was about smoke-free home policies, I'd choose a different causal pathway, a different way of phrasing the process and the problem. So secondhand smoke can damage virtually every organ in the body, and it can travel through doors, windows, and air vents. And children who live in apartment complexes or other types of multi-unit housing are more likely to be exposed to secondhand smoke, even if no one in their family smokes indoors. So this is helping people understand why this is a public health issue, why this is a critical public health protection, not some sort of, invasion into personal choice or privacy. And then the solutions being the smoke-free home policies paired with those programs that help folks into a dependence on nicotine. So this is a supportive approach, not a punitive approach. Point being here, again, none of this is necessarily word perfect. You're welcome to take it and use it verbatim if you want to, but the strategy here is to make sure you're always leading to a strong solution that's collective and concrete and conceivable, and you're crafting the background information and the problem in a way that shines a light on the why of the disparities, not just the who of the disparities. All right, I'm going to pause there for comments or questions if we've got folks.
Julie, we've got another question. Any tips on how to reframe statements when you don't necessarily have an explanation or hard evidence to support the explanation? Maybe you can walk us through that process. Yeah,
well, we're a pretty rigorously evidence-based approach, not empirical, empirical in the service of getting it right and moving us towards the right policy. So I would say if you've got, I want to hear a little bit more about that, because my initial reaction is if you can't explain it, you might need to dig a little deeper and really figure out what it is that's driving the problem before you're able to speak to it. But maybe I'm missing something. And so maybe if the person who asked that could give us a little more explanation, I could be more helpful there.
July, if you have any additional comment to provide there, go ahead and drop it in.
I'll also say, and on the point of hard evidence, I think we've heard that a little bit from folks that are local, and they'll say, I just don't have that type of data, like in my local public health authority, I'm kind of relying on national data. And so one thing that we have found is to say, to give the general process, the causal pathway. So, when children live in multi-unit housing, they're more likely to be exposed to secondhand smoke. You might not have that number for your county or jurisdiction, but we do know that nationally. So say this could help to explain why we are seeing, in my county, kids with lower incomes being 3 times as more likely to miss days due to asthma, or whatever it may be. So you can kind of say this helps to explain why, or this points us in the direction to understand why. That kind of language isn't locking you in to saying this is the reason, but it is pointing up to those higher level processes.
Thanks, Julie. The next question is in the Q&A. When focusing on homeless or low socioeconomic populations, there's often competing issues, especially with the opioid epidemic, that may have priority for other organizations and community groups and community members. Any suggestions for helping to frame tobacco as a priority as well?
Yeah, I think that value of health equity and that the way of expressing it really helps with that everybody, we want to make sure that everyone has a fair and just and full opportunity to be as healthy as possible. And we know, right, that this particular substance causes real health harm. On the topics of co-occurring substance use disorders, I'll refer you to a webinar that we did with the Smoking Cessation Leadership Council with Ryan Coffman, who has done a lot of work to move behavioral health settings in the city of Philadelphia smoke-free, and that co-occurring substance use disorder is one of the things we talked about there. There's some real misperceptions that we have to handle the serious addiction first before we move to others, and that's just not where the science is pointing, to the best of my understanding. I'm a linguist, not a medical doctor, but that sense of saying it's about a full and healthy, a full chance, a fair chance for full health. This is getting in the way. Here's why. Here's the policies that are enhancing that, or ways that we're failing to really ensure that. And we don't have to choose. I wouldn't, I think saying that this is all part of the same work, if we're getting at those underlying causes, we often are doing a lot of that same work. It's a good question, though.
Thanks, Julie. Jessica, you want to weigh in on that?
I think, excuse me, I think you covered it pretty well. I think a lot of times it can be helpful to just look at I went to this training once about the overlap between people who are living with HIV and also have tobacco use. And I think I had this initial reaction, like, why are we worrying about tobacco when there's such a debilitating and deadly disease involved? But then when they showed the data about how much it was shortening people's lives who lived with HIV, just on top of that initial disease, the tobacco use. So I think looking at different ways to illustrate that this is still an issue that's affecting everyone. Does that cover what you were thinking, Sara?
Thanks, Jessica. Julie, have you got time for another question? There's one more in the chat.
You know what? I want to make sure we get Ashley, have her have good time. So I'm pretty sure we'll have time at the end. So maybe we can move on now, and then let's come back to it. So I don't want to short, because people have awesome questions for Ashley, I'm sure. All right, so if we we're leading with justice, we're leading to a solution, and we are connecting the two with really solid explanations. That's this in a nutshell, but putting it into practice sometimes can be difficult. I mean, you all have pointed out just today, like, this wording, that wording, you know, what are ways it is a constant process of refreshing and upgrading language. So if this has not become clear already, we really want to encourage you all to go and check out the resources that this project has created. This is a screenshot of the page there. Sara can probably put the link in the chat one more time, but this does have lots of examples that can guide you, and different things you can use to call in other allies and colleagues to start to change their language and frame on this topic as well. But even better than these resources, we have a real live local public health person, Ashley LeMaistre, who is from Austin Public Health and is a tobacco prevention and control either coordinator or goddess. I forgot her actual title. It's one of those two. But Ashley, if you wanted to come off mute and let us know kind of what your experience has been in working with reframing tobacco from where you sit, that would be great.
Hi, yeah, thank you, Julie. When I met Julie and started working and learning about the Tobacco Disparities Framing Project, our program had been doing tobacco prevention for quite a while, but we had just received a new grant that focused on tobacco within the LGBTQ2IA+ communities. And the resources were wonderful. I was super excited to read through them and learn more about it. That everything just made sense. You know, when you read through it, it just, you know, yes, this makes sense that we should reframe these things and really look at things differently in a different lens than we had previously done. So we really shifted our focus. We had this new project. The topic had been difficult in the past to reach these communities. They had so many other things that, you know, they were trying to work through. And we had to establish the relevancy on this topic for people that don't work in public health. You know, why should this be important to them? We had some new team members coming on that were new to tobacco. So it was a perfect time to share these resources and the knowledge from this project. And we had some staff members created a community advisory board with the framework in mind, and we were able to revise our materials and frame it through this guidance. And this group is made up of community members that are representative of LGBTQ2IA+ and those that work within those communities, has a very strong emphasis on health equity. And it really made people in this group feel empowered about the topic and really start to lead some efforts. And from that, we were able to refresh a lot of our materials and resources. We have a new tobacco prevention PSA that was created. And it's actually the star of the show is a community member, a trusted community member as the messenger. So that was really cool that they were able to step up and present this information. And then ultimately we're working with organizations through this community advisory board that are creating tobacco-free event policies, but with organizations that are serving these communities, which is really great. And a couple of things that we really learned from this is that it's a process. It's a mind shift from how we had previously been framing all of our work. And it does take time to integrate, but I think the results are really great, and we've had some great success. So with that, I will let Julie share our video.
Proud to live the life I deserve, which means not letting tobacco companies tell me how to live my best life. Tobacco companies specifically market to LGBTQ+ communities. By sponsoring pride events, targeted advertising, and even corporate and political donations, they depict tobacco use as a part of our community's culture. But you have the power to imagine change. You have the power to be tobacco-free.
All right, thank you, Ashley, for telling us a little bit about that, as well as that amazing messaging. So Ashley was one of over a couple dozen folks who went through one of two what we call test and learn collaboratives. So one was folks at local health departments and community-based organizations working locally or statewide. And another one was more state and national partners. And so this was across these folks had lots of insights about what it takes to start to reframe, in those in organizations of different sizes. So first, keep it simple. So sometimes had folks look at the research report and say, oh my gosh, everything, I need to change everything. Don't do that. Keep it simple, at least at first. Start with one thing and get some practice. This isn't a one person, one woman kind of initiative. Make some time for back and forth conversations with folks that are creating content in your organization about why these recommendations matter. It's not just a push it out like, hey, I saw this webinar, here's the cheat sheet, do it. But make time for this because it is, some of the recommendations are really counter to the way many of us are trained to write up public health materials, data. And this is not that strategy. In fact, we know that strategy can cause more harm than good. The data can be in there, but it can't be the whole message. So you need some time for those back and forth conversations. We found that folks that were in government agencies, sometimes would have the people doing communications or the people at the program level be familiarized with these materials, but as they sent it through a process to get clearance or approval, sometimes the folks wouldn't understand. So they're saying, why are you starting with this fluffy language about justice? Just say tobacco is the leading cause of preventable disease. And then that would lead to, whereas the program person had just spent, time taking that out and putting in the language about justice. So it can be helpful. Folks found that when they revisited and just re-upped the conversation about why we're making these changes before sending things into that clearance or approval process, that helps make that process go a little bit more smoothly. Also, you can start anywhere, but perhaps start small. Maybe start with short or opening language that you can lift from the guidance that we've provided. There's lots of things. Again, this is a shared strategy. So if you copy something from the work, you're not plagiarizing, you are participating in a shared reframing of this social justice issue. So go ahead and just, start easy and start small. And expect and embrace the reality that if you're going to commit to the shift, it will take some time and effort. And then you can also start to get ideas or show, leadership or others who are a little less familiar or less eager, published examples of this. We are really eager. We have worked closely with Office of Smoking and Health to reframe all of their web pages on disparities. Those are still, I think, in clearance. So I think once that's coming out of the CDC, we hope that will make it easier for folks working in other agencies to start to echo some of that language. But there are lots of early adopter states. So Wisconsin's website, I think, is one of the best examples of this. And then there are dozens of California is doing some really, really great work as well. Massachusetts, so you can lift stuff from them and see how that works for you. And then consider reaching out for technical assistance from either OSH, and if OSH can't handle it, they will reach out to frameworks and we'll see if we are available. But this is definitely, again, because it takes time and effort, because it takes a few reps, we want to make sure that you all know that you've got, where our virtual door is open for a quick look at something or an email. All right, now I think we're ready for more comments or questions.
Thanks, Julie. July or Julie, one of the commenters, I have your question set to the side, but there's one directly on the example that Ashley provided, so I'm going to start there. The question is about the final line of the PSA, which is you have the power to be tobacco free. And this commenter has really helpfully pointed out that kind of puts it back on the individual to make the change. And so there's this tension between the individual from an empowerment perspective, and trying to keep it focused on sort of environmental, structural, and sort of industry-based language. So Julie, while you think about that, I wanted to ask Ashley if you had any feedback about how kind of the script was developed with your community advisory board and what that process was like, if you have anything to add at that level before we get to sort of the theoretical level about the power of empowerment.
Yeah, so I mean, we did want that kind of empowerment message, and the bigger ask is leading them to our website, and they're invited to join our community advisory board and the coalition so that they can be part of that. You know, in media, you only have such a short amount of time that you can say what you have to say, and so sometimes that's pretty challenging in figuring out how to get everything in there that you have to say. And so we did what we could do, but ultimately we get them to our website and they can find out how to do more.
And I think, you know, if I hadn't caught that, but if now I'm thinking about it, you know, simple shift of we have the power to be community, you know, to be smoke free, right? Might have been, you know, you could do just gives that sense that it's a collective action. But I think just the explanation in that PSA, we should not assume that the information that we take for granted, right? That industry is sponsoring cultural events. I mean, to the person asked about rural earlier, you know, rodeos and things like that, and NASCAR, you know, events, and ensuring that there's you know, ads showing kind of rugged individualism, masculinity kind of stuff with certain types. So it does not matter which community we're talking about, right? They have figured out a way to target and tailor ads to make it seem like tobacco is part of that cultural lifestyle. That's a general causal pathway that we can teach America, and then but give the details, right, that are specific to particular you know, ethnic or social groups, racial, ethnic or social groups that really make it seem like, wow, this is affecting us, but it's also affecting all of us in this particular way. So I think the explanation there is really great, and yeah, good point. Every reframe can be reframed again. So maybe a we at the end there, but I think it was lovely. Yeah. Okay, July's
Thanks,
question.
Julie. Yeah, I copied it in there. There you go. And I also want to say, I think that's the really highlights the significance of having a community advisory board who puts that work together and is reviewing that language, because you can edit anything into the ground, right? But deciding what to take action on, if you've got community input and you've got trusted messengers, you can make those calls a lot easier, I think. Or at least more confidently. Okay, Julie, I'll let you tackle Julie or July's question.
Yeah, I think that, okay, so the question here is that you've got some data illustrating that there's a disparity, and you want to bring in the community partners early. How do you present that data without sounding like you know, doom and gloom or putting blame on that community? So one thing you might consider, of course, you know, you're going to have probably at your fingertips, just by virtue of the kinds of questions we tend to ask in public health, the prevalence, you know, of use or inequities in negative outcomes, health outcomes. So you'll have that. Or can you ask a couple more questions that really point to environment? So things about, you know, retailer density, points in certain neighborhoods, points about advertising practices, or the number of retailers that have been cited for selling underage, the number of, you know, the location, not just the density, but the location of retailers in your schools. I don't know what the data might be, but can you bring that data that is about the direct observable effects in the bodies, right, with data about the direct measurable observable drivers in communities, right? And so looking to those, and then I think you'll get people connecting dots there, right? And certainly you can lead to that, lead folks to that, facilitate the conversation in a way that really highlights the structural drivers. Oh,
Thanks.
good. Yes, that resource you popped in is really
Yeah.
good.
This is our recent resource about how community assessments and data are at the heart of equity. So that's a really a great question, really on point. I just popped the link in there. The next question is a state organization which is averse to calling out big tobacco as part of the problem. Any suggestions for addressing or changing this?
So yes, I have a lot. All right. So first of all, we should not assume that when we say the phrase big tobacco, that carries all the meaning that it once did. Our research suggests that the public right now has a sense the tobacco industry plays dirty. They're kind of vague and nefarious, but it does not have the actual practices that are coming that they're using are not well known. So you don't have to use the phrase big tobacco at all. If you do, please, sorry, I'm in DC and the motorcade's going by. Hi, Biden. You don't have to use the phrase big tobacco. If you do, please explain the contemporary practices. Naming practices, right? You could say in our city, right now, we, City X, are allowing, this many number of retailers, which means this many number of outdoor ads within this many feet of schools, right? You don't have to say the phrase big tobacco to do that. So you could point to practices rather than attribute responsibility kind of by name. That's one thing you can try. The other thing is, it sounds like perhaps you're at a state agency, call on your advocacy allies, right? They can, they may have liberty to say things that you can't in a government agency.
Thanks, Julie. It looks to me like I've got nothing coming through on the Q&A. Everyone, please do pipe up through the comments if you have any other questions coming up. I'm just once more going to copy the link to all of the tools and products and research that we've based this presentation on. And again, all of the links that came up through the chat, the resources, the link to the FDA comment page, we'll put all of that in the follow-up email along with a survey link for everybody. So you'll have access to that with the recording.
Yeah. And as well as, what we should also add is access to what I like to call the secret menthol messaging memo, which isn't in the toolkit right now, but we sent that out today to folks. So via our channel, so maybe we could put that in. It's just a small study that was sponsored by the American Heart Association on how to respond to things that are sometimes heard in Black communities, in particular, once the issue of banning the sale of menthol comes up. So someone at the top of the call mentioned that. So we were able to do some limited pressure testing on different responses to, the fact that it's going to lead to more arrests, right, in Black communities for possession of menthol, those sorts of things. So what to do? Don't say no, it won't. That's not what that's not where the enforcement is. It's true that that's not where the enforcement is intended to be, but kind of saying no, don't worry. Police aren't going to bother anyone in those neighborhoods, right? Is not A, probably not true, but B, definitely not a winning response. Instead saying that that's a talking point put out by the tobacco industry, and because concerns about community policing are so legitimate and so pressing, it's really shameful that they would exploit it in that way, right? So kind of some different ways to respond to many of the objections that are happening, some organically, but honestly, many of them kind of planted by industry defenders.
Thanks, Julie. That's incredibly helpful, incredibly timely. Yeah, I say we let folks go early.
Yes, let's do it.
Awesome. Thank you again, everybody, for joining. Watch for the email with the link, with the survey link, with all of the resources that we provided. Reach out to us, reach out to me. To Julie, we are all here. And thank you again to CDC OSH for funding this work and today's webinar.
Bye for now.
Bye for now, everyone.
Frame on.
Thanks to you, Coop.
Yep, I'll end it right now. Thanks.
Bye.